Yes, good. So, my topic here today is to discuss with you the phenotypes of vascular aging. And I've added, obviously, a very important aspect to this, which is how do these phenotypes of vascular aging end up influencing our clinical practice? These are my current affiliations. I have no conflicts of interest to delivering this talk. And I have divided it into four specific topics that you can see here and that I hope to develop during this presentation. So as an introduction, I obviously showed these slides so many times, the revision of the cardiovascular continuum and its division into the atherosclerotic continuum and the aging continuum. That it was done by Michael Rourke, Michel Safar, and Victor Zhao. But this year, this has a particular meaning as Professor Zhao, Professor Safar, and Professor Rourke have left us in the beginning of the year. So I show this slide today not only as a testimony of their work and their life dedication to the topic, but also to show you from where this concept has stemmed from. On the other hand, we've also gone from looking into younger arteries with their full ability of absorbing energy during the incident wave and delivering a laminar flow to the microcirculation and decreasing the risk of hypertension-mediated organ damage or subclinical organ damage, as opposed to those who have suffered changes to the medial layer and these arteries with low distensibility, with high arterial stiffness, who are not capable of absorbing pulsatile energy and in the end transmitted to the microcirculation, increasing the risk of target organ damage. But we have also evolved in our way of thinking this cardiovascular aging continuum and the influence of mechanical changes in both arteriosclerosis and atherosclerosis has evolved, and we now know that the board is a very much complex figure that must be understood as a continuous and a concomitant influence of different risk factors, epigenetic markers, inflammatory and biochemical changes that in the end will promote the appearance of these two distinct diseases. And for more detail, you should also be aware that there are different signatures for the appearance of arteriosclerosis, and that we now are able to strictly define at least four different ways of evolving to changes in the inner layer, in the inner medial layer of large arteries that promote decreased arterial distensibility, increased arterial stiffness, and more risk of cardiovascular disease. In fact, in clinical practice, we now do know that the tracking of biological aging using different modalities of imaging is possible, and that these features of our arterial function are included as some of the most confident and most valid ones that we can use when analyzing geometric features associated with aging and functional features associated with aging with different techniques. Finally, to let you know that the concept of vascular aging and pulse wave velocity as a marker of vascular aging have been embraced in part to explain the relationship between ventricular elasticity and arterial elasticity, and of course the ventricular arterial coupling. And this has led the European Society of Cardiology to include the arterial stiffening mechanism as one of the core mechanisms that explains how we get to have heart failure and also subendocardial ischemia, and therefore why we should look at this as a particular mechanism to address when we are faced with our patients with increased arterial stiffness. So what about chronobiological asynchrony phenotypes or vascular aging phenotypes? So we've known since 2010 that patients within the same age range do not have the same pulse wave velocity. And of course, indeed, that if you can determine the median value that you are expected to achieve through a normal vascular aging process at your age range according to your gender, you should know that there are patients that go over or below this median value, and this should have consequences. In fact, we were able to show in a population of more than 3,000 subjects that the prevalence of these patients whose biological age is higher than their chronological age, which means that their arteries have the age of someone older than them and have a higher risk of cardiovascular disease, is in fact of 12.5%. But as you can see here, subject below 40 years of age and particularly below 30 years of age already shows changes that are approximately 26% of them presenting with early vascular aging. Afterwards, in the last committee, we were able to show that patients that have a higher biological age than expected in their arteries, i.e. changes that come quicker to their arterial distensibility and to their arterial stiffness, these patients have a higher risk of developing both hypertension-mediated organ damage and cardiovascular disease, especially when compared with those that have an average evolution of pulse rate velocity, or those who, and especially from those who have an ideal life course. So how to address this issue? The first group was the group from Framingham that compared those that they would consider to have healthy vascular aging, very low pulse rate velocity, no hypertension, patients over 50 years of age. First of all, to let you know that patients that preserve this arterial function as immaculate as they have defined are only 30% of those who are in the ages between 50 and 59 years. But more importantly, if you follow these people for approximately 10 years, you'll see that those that have healthy vascular aging that preserve their arterial function when compared to others with more accelerated vascular aging, they have a 55% reduction in the risk of developing cardiovascular disease. Across the pond in Europe, a cohort of more than 18,000 subjects compared those that had healthy vascular aging with those that had early vascular aging as a mark of the 10th percentile of the distribution of pulse rate velocity of these 18,000 patients, only to show that patients at the same age group but that were healthy had a 14 years difference in the biological properties of their arteries and therefore a lower risk of developing cardiovascular disease. And then we come to the part where we mixed astronomy with arterial vascular aging. This is the life cycle of high-mass stars. And as you know, when a supergiant explodes, a black hole is created. And within this black hole, time bends, and it does not seem to pass. So for these people, time does not influence the arterial properties of their arteries, and they would be able to keep the biological features of the articles, no matter what exposure to risk factors or to influences that would change their arterial stiffness. And this is how we came to propose the supernova concept, the concept that within the different phenotypes, you've seen the early vascular aging, the average or normal vascular aging, and the healthy vascular aging, but that there will be an extreme of supernova subjects, those that for whom time does not pass and their biology of their arteries is not changed, and that they would keep their distensibility and low stiffness to their arteries. And we have put this to the test with a study done with the Reference Values Cooperation, estimating vascular age from a combination of their pulse rate velocity, their medication, and the influence of different cardiovascular risk factors, and then comparing this estimated biological age with their real chronological age, and defining those that have early vascular aging and supernova as the extremes of the distribution of this cohort, and then validating these definitions in the Malmo Diet and Cancer Study cohort, only to show that those that have supernova, which is that they have a chronological age that is 6.2 years higher than their biological age, i.e. their arteries have not aged, they have a 41% lower risk of cardiovascular events and cardiovascular disease, as opposed to the early vascular aging subjects that have 2.17 times higher risk of cardiovascular disease. So these are the four phenotypes that we can identify from the evidence that I've shown you previously, and it is important to learn what are their clinical implications. So at the first glance, you look at these vascular phenotype implications, and you can divide them through 5 groups. The ones that have early vascular aging with established arterial stiffness, which is a marker of subclinical and hypertension organ damage, where you have a strict control of cardiovascular risk factors associated with the need of a more specific treatments that we will discuss later on, to comparing with those with early vascular aging, but that still do not have arterial stiffness, and of course with those with normal healthy vascular aging, to whom the amount of intervention is mainly preventive, and primary prevention is particularly important. And you leave the supernova group for research models, obviously not forgetting the lifetime and the life course approach, and the understanding that these patients, for some reason, for some exposure at a particular time of their life, may, of course, change their phenogroup and be in need to have some sort of intervention. But let's look at how we see this evidence through the eyes of very important trials that have been published in the last 4 years. And you will look at the ARIC and the NHANES study to show you that though in these very long longitudinal studies, those who have lower pulse rate velocity were the ones that had a significant decrease of the ability of developing cardiovascular disease, of cardiovascular events, especially when their lifestyle has been strictly followed, and have a higher number of markers of healthy lifestyle, according to the WHO, that are obliged with. So different phenotypes can also be used in different risk stratifications, especially because of the knowledge we've accrued pertaining pulse rate velocity. We know that it is an independent cardiovascular risk marker for cardiovascular disease, cardiovascular mortality. This is particularly true for this second meta-analysis that shows that particularly for younger age, pulse rate velocity is a very important marker of cardiovascular disease and mainly cerebrovascular events. But the evidence that I want to highlight today is the one coming from Framingham, showing that one very important issue is that pulse rate velocity is the most, pulse rate velocity and arterial stiffness is the most prevalent hypertension-mediated organ damage in our patients. And so if we do not measure pulse rate velocity and evaluate the vascular aging phenotypes of our subjects, of our hypertensive subjects, we are clearly depriving them of a particular tool to correctly stratify the risk that they have, and therefore intensify or not their treatment targets and their therapeutic. The same, and taking advantage of the topic of our conference, has been shown for the role that arterial stiffness plays to not only to the development of cardiovascular disease, but also cardiometabolic and chronic kidney disease through time in patients with higher pulse rate velocity, with higher than expected for their age, with accelerated vascular aging, have a higher risk of developing not only cardiovascular disease, but also cardiometabolic and chronic kidney disease. And finally, the importance of vascular aging phenotypes is not only their direct importance as influencing or determining independently the risk of developing cardiovascular disease, but also in particularly the influence that they have on the development of other target organ damage, and therefore in an indirect manner strike twice on the risk of cardiovascular disease, one through their directory interaction and independent predictive power for the development of cardiovascular disease, and the other through the interaction with other organs and their ability of developing subclinical organ damage. And as you can see, if it is true that target organ damage is very important in determining the cardiovascular risk, so are other markers of arterial function, and obviously that determine different phenotypes of vascular aging in the development of cardiovascular disease. So what about treatment? Is there already enough evidence to show us that different phenotypes of cardiovascular aging should be treated? This is a very tricky question, and I will show you the existing evidence, which has been growing over the years, and I hope that can give you shed some light on how to use arterial stiffness to better treat your patient. As you know, the SPARTA study has been one of the most important studies that has been done in the past few years. It was underpowered. It could not show that if you treat directly pulse wave velocity, you have better clinical outcomes. But it could show that if you pay attention to pulse wave velocity and treat it directly, you'll have a better blood pressure control in the end. And as you can see in the right panel, you can also decrease the evolution of pulse wave velocity, decrease the evolution of arterial stiffness and the risk that they inflict in patients, making them more susceptible to cardiovascular disease. Other information comes from this meta-analysis showing that if you decrease pulse wave velocity directly, you also decrease left ventricular mass, which obviously is an independent risk factor for the development of cardiovascular disease. More importantly, in the SPRINT study, a post-hoc analysis could show that those patients that belong to the intensive treated group and that responded with a decrease of cardiovascular morbidity and mortality were only those who had a concurrent decrease in pulse wave velocity that was estimated through an analysis of the different features of the patients. So again, highlighting the importance of decreasing not only blood pressure, but also pulse wave velocity in the process. And the most hard evidence that we have today also comes from the SPRINT, but the SPRINT Heart study that measured the evolution of stiffness and also the evolution of decreasing pulse wave velocity through a method of combined echocardiographic and MRI evolution to show that whenever you decrease pulse wave velocity, you will have a decrease in cardiovascular events, such as that per each standard deviation of pulse wave velocity, you get a decrease in 51% of the risk of cardiovascular events, cardiovascular events. The caveat of this evidence is, of course, that this has been a smaller study that needs to be externally validated. So I would sum up these evidence that I've been showing about the early vascular aging and their implications for clinical practice with this very important central illustration by Weber and Chirinos showing us how pulse wave velocity and early back wave reflection has an important pathophysiologic role into the developing of different cardiovascular disease and especially heart failure, to show you also that we can use phenogroups and pulse wave velocity to characterize our patients with heart failure. This is from the TOP-CAT study, showing that the phenogroup 2, which was the one that had increased arterial stiffness, was the one that was less responsible to the introduction of spironolactone as a treatment for these patients with HFpEF that needed to have their treatment adequated, and that in contrast, patients in the phenotype 3 with not as high arterial stiffness were responsive to spironolactone, again enhancing the importance of precision medicine and how we can use phenogroups and pulse wave velocity to be included in the distinction of how we can treat patients. And the same could be said in the study, the Stanilas study that used different biomarkers, not only biomechanic biomarkers, but also molecular biomarkers to define 3 different clusters. And as you can see, pulse wave velocity was determinant in 2 clusters, the 2 clusters in the right hand of the panel, where you can see that the risk of cardiovascular developing heart failure and cardiovascular disease or cardiovascular death were significantly increased. And this was done in patients that were, of course, at the beginning asymptomatic, and therefore to whom we could predict a more gruesome development of disease if we would have to apply these characterization features, including pulse rate velocity and phenogroups. And finally, we can see that today we already use phenogroups of vascular aging when we want to decide which one of our patients will respond to renal denervation. And we know that for patients with higher pulse rate velocity, they will not benefit as much from renal denervation as those who keep some part of their arterial distensibility, even if being a resistant hypertensive. So to conclude, I would show you this picture that looks very complicated, but that in the end summarizes how time and risk factors are influences in the development and the increase of risk of cardiovascular disease, and how the different phenotypes would be allocated in terms of increased risk or increased susceptibility to these risk factors, and helping you to establish a phenogroup for your patient and to act accordingly. I would finish inviting you to take a look at this book. We have just put it out. It's a revision of everything we know about early vascular aging with new perspectives for translation on precision medicine. It has 54 chapters and 84 international authors. It has been scientifically endorsed by these 3 societies, and so it would be a pleasure for us if you could take a look and give us your opinion on this book. And again, also to invite you to the next meeting of the Artery Society that will take place in Cardiff this year in October, and it would be a pleasure to have you there, just as much as to receive you in our hometown in Guimarães. I'm sure you would enjoy, and we will receive you with arms open. Thank you very much for the invitation.